Welcome back to the deep dive. Okay, I want you to try something for me right now. Just take a swallow. Or say the word specific. You didn't really think about it, did you? You just did it.
No, it's automatic. We completely take it for granted.
Exactly. But today we're focusing on the engine behind that automation, the tongue.
Yeah.
It is arguably the most complex muscle architecture in the body relative to its size, and we usually just ignore it until, of course, it turns against us.
And when we say turns against us, we're not talking about, a burnt taste bud from hot pizza.
Right.
We are talking about squamous cell carcinoma.
Right.
It is a beast of a disease. Not just because of cancer, but because of where it is. It strikes the very intersection of how we eat, how we speak.
How we socialize, even how we breathe.
Exactly.
We have a really fascinating set of sources today. We're looking at 3 specific medical case studies that they really run the whole spectrum of human experience.
They really do.
We have a 60-year-old grandmother with 0 bad habits, a chronic smoker, and a case that involves, well, a folk remedy that, honestly, it just shocked me.
The kerosene case.
Yeah, the kerosene. We'll definitely get to that. But our mission today is to map the whole journey. We're going to go from that first detective phase of diagnosis right through the high-stakes chess match of surgery and end up at what I can only call bioengineering.
Literally rebuilding a tongue from scratch. It's a journey from pathology to plasticity.
And the takeaways here are surprisingly relevant, even if you think you are, low risk.
Especially that.
So let's start there with that risk. The detective work. I think most people have a mental image of an oral cancer patient, the stereotype.
Oh yeah, an old man, chain smoker, maybe a heavy drinker.
Right.
And we do have a case just like that in the stack up. A male patient, smoker for 30 years, alcohol user. And that represents what we call the synergistic effect.
Synergistic. So meaning they multiply the risk, not just add to it.
Exactly. It isn't 1 + 1 = 2. It is exponential. See, tobacco, it dries and damages the mucosa, that delicate lining of the mouth.
Okay.
Then alcohol acts as a solvent. It washes away the protective mucus, and it helps the carcinogens in the tobacco penetrate deeper into those already damaged tissues.
Wow, so it's a perfect storm for cellular mutation.
Perfect storm.
Okay, so that's the textbook case, the one we expect. But then I read the file for the first patient, a 60-year-old female, no tobacco, no alcohol, no betel nut, healthy mixed diet. And yet she walks in with a 2-month-old ulcer on the side of her tongue that turns out to be cancer.
This is the case that keeps oncologists up at night. I mean, it completely shatters the smoker's disease stereotype.
So what caused it then? Just bad luck?
In many ways, yeah. It could be a genetic predisposition, or, it could be chronic trauma, like a sharp broken tooth just rubbing against the side of the tongue for years. That chronic irritation can sometimes trigger cellular changes. But the real insight here for listeners is that low risk does not mean no risk. She had no family history either.
That's terrifying. It means you can't just dismiss a sore spot because you live a clean life.
You can't.
But then we have the second case, the 55-year-old female. Now, she was a Panama solid chewer, so she had risk factors. But the clinical notes mention something. Well, bizarre. She was using kerosene oil on her tongue.
Yes, this detail, it stops everyone in their tracks. But you have to try to look at it through the lens of pain management, not just as like a random act.
Kerosene, it's fuel,
Right.
It's what you put in a lamp. Why would you put that in your mouth?
Because it burns. It acts as a counter-irritant. She likely had severe pain from the developing cancer, or maybe a pre-existing gum disease.
Okay.
And the intense burning sensation of the kerosene would temporarily distract her brain from the deep throbbing ache of the tumor.
So it's like hitting your thumb with a hammer so you forget you have a headache.
Precisely, it just overrides the pain signal. But chemically, it is a disaster. You're putting a toxic hydrocarbon on a mucosal surface that's already trying to heal.
And it highlights that tragic reality you see in these cases, the patient delay.
Exactly. People try to self-medicate with folk remedies, salt water, clove oil, or in this case, kerosene, just hoping it'll go away.
Meanwhile, the tumor is just getting bigger and bigger.
And by the time the pain is unmanageable, even with the kerosene, the cancer has probably moved from an early stage to a very advanced one.
So if we can't rely on patient history alone, since our first patient had no history, what are the actual red flags? Aside from a sore that won't heal. The case studies mention 2 terms that sound awful, trismus and ankylosing.
They feel about as uncomfortable as they sound. Trismus is, it's essentially lockjaw. The patient physically cannot open their mouth fully.
And that's caused by the tongue tumor. How?
Indirectly. It usually means the cancer has infiltrated deep enough to hit the pterygoid muscles. Those are the muscles near the back of the jaw that control opening and closing.
Yeah.
So if a patient with a tongue sore says, "Doctor, I can't open my mouth wide enough to eat a sandwich," that is a massive alarm bell. It signals deep invasion.
Okay, and ankylosing.
That literally means tongue-tied. But not in the way we think about it for babies. This is acquired.
Right.
It means the tumor has basically glued the tongue to the floor of the mouth. The tongue should be free and mobile, right?
Of course, yeah.
If you ask the patient to stick their tongue out and it deviates to one side, or they just can't lift it, the tumor has invaded the intrinsic muscles.
That explains why the notes mentioned her speech was slurred. You literally can't form words if your tongue is anchored down.
Correct. And there was one other symptom in the notes that I found incredibly counterintuitive: referred pain.
The earache.
The earache. Right. The patient comes in complaining their ear is killing them, but the doctor immediately checks the tongue.
Why? That feels like some kind of magic trick.
It's all about the wiring. The sensory nerves that supply the tongue, the lingual nerve and the glossopharyngeal nerve, they have branches that sort of crosstalk with the nerves supplying the ear.
So the brain gets confused.
The brain gets completely confused. A deep burrowing cancer in the tongue sends out pain signals, and the brain misinterprets them as coming from the ear.
So an unexplained earache could actually be tongue cancer. That is wild.
It's a classic distraction symptom.
Right.
And if a doctor just treats it as an ear infection without looking in the mouth, you lose valuable time.
Okay, so the detective work leads the patient to the chair. The doctor sees the lesion, but the notes say they don't just look, they feel. They talk about induration. What does that actually feel like?
Okay, think of the difference between your cheek and your forehead. Your cheek is soft, it's pliable.
Right.
Your forehead is hard bone. A healthy tongue is soft, muscular tissue. Cancer feels indurated. It feels woody, hard, almost like a button or a pebble sewn into a pillow.
That is a vivid image. And they use the term ulceroproliferative.
Yeah, that just describes the behavior of the growth. So an ulcer is a hole, a crater digging down.
Okay.
Proliferative means it's growing out, like a cauliflower. Ulceroproliferative just means it is doing both of those aggressive things at once, eating into the tongue and piling up on top of it.
Visually nasty. But the surface is just the tip of the iceberg, right? This is where the MRI comes in.
Exactly.
Why is the MRI so critical if you can already see the tumor?
Because of everything you can't see. The tongue is a superhighway for nerves and blood vessels. The MRI is what assesses the depth of invasion, and that is the most critical metric for the surgeon.
Why? Does it change the actual surgery?
Completely. If the depth is shallow, say less than 4 millimeters, the risk of it spreading to the neck is lower. But if the MRI shows the cancer is diving deep, or if it shows paraneural invasion, the whole game changes.
Paraneural invasion? That sounds like the cancer is using the nerves as a tunnel.
That's exactly what it is. It's using the nerve sheath as a path of least resistance to travel away from the main tumor, maybe heading toward the brainstem or deeper into the neck.
And the MRI can see that.
The MRI helps us catch that silent spread before the surgeon even picks up a scalpel, and that determines the T stage.
Right.
T1 and T2 are smaller, roughly under 4 centimeters, not too deep. T3 and T4, like our recurrent smoker case, those are the monsters. They've invaded bone, deep muscle, maybe even the skin of the face.
All right, let's move to the operating room, segment 3. The high wire act. The surgeon has to cut this thing out. But the tongue isn't like a liver, right, where there's a clear capsule. It's just muscle merging into muscle. How do they know where to stop cutting?
This is the whole concept of the safe distance, or what we call the surgical margin. The goal, generally, is to take the tumor plus a 1 centimeter buffer zone of healthy tissue all around it.
A centimeter sounds huge when you're talking about a tongue. That's a lot of real estate.
It is huge. You are absolutely sacrificing function for survival. But here's the problem. Biological tissue shifts. When you cut the tongue, the muscle retracts. It wobbles. It's not like cutting wood or stone.
It's fluid.
It's fluid. So how do you verify you got it all? You can't wait a week for a lab report while the patient is open on the table.
So what do?
Enter the frozen section. This is one of the most high-pressure 20 minutes in all of medicine.
Walk us through this. I was picturing a chef tasting a sauce, but this sounds way more intense.
Oh, it is. So the patient's asleep. The surgeon cuts out the tumor. They immediately slice off a tiny sliver from the margin, the very edge of the hole they just made.
Okay.
A runner takes that tissue straight to the pathology lab down the hall. They flash freeze it with cryogens to about minus 20 degrees Celsius.
Why freeze it?
Because fresh tissue is soft and squishy. You can't cut it thin enough to see under a microscope. Freezing it makes it hard instantly. They slice it paper thin, stain it, look under the scope for cancer cells at the edge, and they pick up the phone.
And the surgeon is just waiting.
Scrubbed in, hands in the air, basically staring at the clock. The pathologist calls and says either negative, which means clear, or positive.
And if it's positive?
The surgeon picks up the scalpel and cuts more. They have to keep chasing the cancer, taking another centimeter and another until those margins are clear.
Wow. That's unbelievably intense. And while they're doing that, they're also dealing with the neck, right? The neck dissection.
Yes, and this confuses patients all the time. They ask, I have cancer on my tongue, why are you cutting open my neck?
It does seem aggressive.
It's precautionary. The tongue has an incredibly rich lymphatic drainage system. Cancer cells love to hitch a ride in the lymph fluid down to the nodes in the neck.
I see.
So even if the MRI looks clean, there's a risk of occult metastasis, microscopic spread that imaging can't see yet.
So they just clear out the lymph nodes just in case.
For larger tumors, yes. They'll usually strip out levels I and I, the nodes under the chin and jaw, but for smaller cases, like our 60-year-old lady with the T2 tumor, they might use a smarter technique.
The sentinel lymph node biopsy.
Exactly. I've heard of this in breast cancer. It's like finding the gatekeeper.
That's the perfect analogy. They inject a radioactive tracer or a blue dye into the tumor. They watch where it flows first. The very first node that lights up or turns blue is the sentinel.
And they just take that one out.
Just that one. If it's clean, they assume the rest of the chain is clean and they leave the neck alone. It saves the patient a huge scar and a lot of post-op stiffness.
Okay, so the tumor's out, the nodes are checked, but now you have a patient with a massive hole in their mouth. In that recurrent case, the defect was 7 by 6.5 centimeters. That's most of the tongue.
It's a devastating defect. If you leave it, they can't speak, they can't swallow, they can't protect their airway, you can't just stitch the edges together either because the remaining tongue would be so tight it couldn't move.
You'd have that ankylosing again.
Exactly. So we enter the bioengineering phase. Reconstruction.
Right. We need to patch the hole with living tissue that brings its own blood supply. We call these free flaps.
Free, meaning you completely detach it from one place and move it to another.
Yes. You cut the tissue, you find the artery and vein feeding it, you cut those, move the whole chunk of flesh to the mouth, and then you sew those tiny vessels into arteries and veins in the neck.
Under a microscope.
Under a microscope, it is plumbing on a millimeter scale.
And the sources talked about two main donor sites, the wrist and the thigh. Why pick one over the other?
It is all about volume. The radial forearm free flap from the wrist is thin, pliable, and usually hairless. It's perfect for patching a smaller hole where you want the tongue to stay mobile.
Like a patch on a tire.
A very sophisticated patch, yes. But for the smoker case, the one with the 7 centimeter whole wrist skin is way too thin. It would just be a flat sheet.
You need bulk.
You need bulk to fill that empty space so the patient can push food against the roof of their mouth to swallow. So they go to the thigh, the ALT flap.
Anteroral thigh. It comes with skin, fat, a tough layer called fascia.
It's a slab of meat, frankly.
Now, this is the part that really caught my eye, the math.
Yeah.
The surgeon noted the hole was 7 by 6.5 centimeters.
Right.
But they harvested a flap from the thigh that was 10 by 10 centimeters. That's almost double the surface area.
This is the shrinkage factor, and it's a brilliant bit of foresight.
It seems like a mistake. Wouldn't a 10 centimeter tongue be too big to fit in the mouth?
Initially, yeah, it is bulky, but you have to account for two things. First, once you cut the skin from the thigh, the natural tension releases and it shrinks a little immediately. But the bigger factor is what comes next.
Radiation.
Radiation, the adjuvant therapy. Almost all advanced stage patients will get post-op radiation. And radiation causes fibrosis, scarring. It makes tissues tighten up and shrink down significantly. So if you've built the tongue to be the exact perfect size on the day of surgery, 6 weeks later, after radiation, it would be a shriveled, hard little lump.
The patient wouldn't be able to talk.
Not at all. So they intentionally build a megatongue, knowing the radiation will shrink it down to the correct size.
They're engineering for the future state of the tissue, not the present state.
It is bioengineering with a time variable. It's incredible.
It is incredible. And speaking of radiation, the notes mentioned cobalt-60 and brachytherapy. What's the difference there?
Cobalt-60 is external. The beam comes from outside the body. It paints with broad strokes. Brachytherapy is it's detail work. They place radioactive catheters or seeds inside the tumor bed itself.
Like planting mines.
In a way, yeah. It delivers a massive dose of radiation just a few millimeters deep, sparing the surrounding normal tissue. It's often used as a boost or to mop up if there were positive margins or what we call extracapsular spread.
That's when the cancer bursts out of the lymph node.
Exactly.
It is just layer upon layer of safety nets.
Okay.
Surgery, the margins, the frozen section, neck dissection, external radiation, internal radiation.
And yet, despite all of this, the recurrence rate remains high for late-stage disease.
Which is why the detective work at the beginning is the most important part of this whole story.
It really is. I mean, if our 60-year-old lady had waited another 2 months, she might have needed the thigh flap instead of the wrist flap. She might have lost her ability to speak clearly.
And the kerosene patient.
If she had gone to a dentist instead of, the hardware store for her pain relief, she might have avoided so much of the suffering she endured. She probably delayed her diagnosis by months trying to self-treat.
It really highlights that gap between anatomy and function, doesn't it?
Mhm.
We can rebuild the anatomy. The surgeons can take a piece of a thigh and make it look like a tongue.
They can make it look like a tongue. They can make it fill the space of a tongue. But let's be absolutely clear. A thigh flap cannot taste a strawberry. It doesn't have the exquisite sensory feedback to know exactly where a crumb is.
Or the motor control.
None of the fine motor control to trill an R or articulate complex sounds.
So the patient is saved, but they're left with this block of tissue that is essentially a passive passenger in their mouth.
They have to relearn how to eat. They have to relearn how to form words using a part of their leg. It's a massive quality of life shift. It's a victory, yes, but it is a victory with a cost.
Which just brings it all back to early detection.
2 weeks. That is the golden rule. If you have an ulcer, a white patch, a red patch in your mouth that does not heal in 2 weeks, get it biopsied.
Even if you don't smoke.
Even if you don't smoke, even if you don't drink.
And for the love of everything, don't put kerosene on it.
Please leave the kerosene in the lamp.
A grim, but a really necessary deep dive today. It makes you appreciate that simple act of swallowing a little bit more, doesn't it?
Absolutely.
Check your mouths, everyone. We'll see you on the next deep dive.